The patients during the trial who died, and who I mentioned that were severely affected, were all patients who were ventilator dependent, and fully ventilator dependent. Yeah.
And also the patient who had sepsis and the decubiti who passed on.
Yeah.
Did they have the decubiti prior to receiving treatment?
What did he have prior to start of treatment? A tube?
Yes, did they
Yeah,
have
yeah,
the decubitus
yeah.
prior to starting treatment?
No, but this was a patient who was very severely affected and who was hospitalized and was very severely ill, and during this process of being very severely ill, he also developed decubitus and eventually a sepsis, and that was the reason why he died.
Thank you.
Yeah.
Only if there's an urgent question, because we have a question session. So if you don't mind, we are a little bit behind. Yeah, thanks a lot.
Yeah.
So we take your computer.
Yeah.
So first of all, I would like to thank the AMDA for having me here for this presentation today. My name is Gungor, and I'm a researcher at Erasmus Medical Center Rotterdam, the Center for Lysosomal and Metabolic Diseases. And today I will give you a presentation on the AMDA AMDA POMPE survey project, and I will give an update and show some of our latest results. So the first part of the presentation I will focus on how and why the survey was developed and go more into detail about the objectives and design of the study, including a short update, and thereafter I will discuss some of our latest preliminary results on effects of ERT on fatigue and life expectancy in adults with Pompe disease. But first of all, I would like to start with the value of patient-reported outcome measures in clinical research. So why are patient-reported outcome measures important? Well, first of all, they can reflect the patient's point of view. Furthermore, they show you how what the impact of the disease is on patients' lives, and they can complement other outcome measures like laboratory values, muscle strength, and respiratory function measurements. And of course, what is the ultimate goal of any treatment? That is that a patient feels better and is able to resume his or her previous activities. So the importance of patient-reported outcome measures was also acknowledged by the FDA in 2006 when they released a document emphasizing the importance of these kind of measurement scales in clinical research. So here you can see the link to the document if you're interested. Well, what was the rationale behind the AMDA POMPE survey? Well, in the years before ERT got approved, there was a need to understand the variability, the progression, and the natural course of this heterogeneous group of Pompe patients. And we wanted to learn more about the impact of the disease on patients' lives. So this way, the effects of ERT or other future treatment options could be fully evaluated. And this need was recognized by the International Pompe Association together with Erasmus Medical Center. So they jointly started in 2002 this project called the AMDA POMPE survey, or for short, just the Pompe survey. So the Pompe survey is an ongoing international study in which patients complete yearly self-report questionnaires, and its goal is to gather information on the clinical course of the disease, the severity of the disease, and the impact on the daily life of the patients. And all patients who are diagnosed with Pompe disease can participate. Patients were recruited through patient organizations from the Netherlands, the United States, the UK, Germany, Australia, Canada, and some patients from other countries. So, what kind of questionnaires are in the Pompe survey? Well, first of all, we have the Pompe questionnaire, which is a specific questionnaire developed for patients with Pompe disease, and it covers topics on diagnosis, family history, development, current situation, and so on. And then we have the fatigue severity scale, which is a brief, simple questionnaire on fatigue and the impact on patients' lives. And we have the Rotterdam Handicap Scale included, which assesses the level of participation in daily life situations. And this concept is also formally known as handicap. And then we have the SF36, which is a well-known quality of life questionnaire. So after ERT became available, the survey, the questionnaires, and the protocol were updated, and evaluating the effect of treatment was added to one of the goals. And within the scope of this new protocol, we also developed a new web-based application which enables for patients to complete the survey through a secured internet website. And next to the English, Dutch, and German questionnaires, we now also have the survey available in French. So we recently started including French patients to the survey. And we have now also a new child version of the Pompe survey developed especially for children with Pompe disease and their parents. The child version also has the same kind of measurement scales as for the adults. And furthermore, this is not applicable yet, but we want to link the data gathered from the survey to patient registries, such as the Pompe registry, so you can combine clinical data with patient-reported outcome measures. So this is a picture of how the old paper survey looked like. Maybe some of you recognize this. And then now you can see the web-based survey in which you can click the answers that are applicable to you and skip some of the questions that are not applicable, so it's much shorter to complete. As I mentioned, we have participants from all over the country, all over the world actually. You can see that the largest group is from Germany, from the Netherlands, and from the US. We have 86 participants from the US, so that is quite a lot. And because of the continued participation of all the patients, the information gathered from the Pompe survey has led to several scientific publications in peer-reviewed journals, especially on the natural course of Pompe disease. And also these data have helped to get Enzyme reimbursed in the Netherlands for Dutch Pompe patients. So in conclusion, we can say that the IPA RSMC Pompe survey is an important tool to include the patient's view on the disease severity, progression, and treatment effects. And the new web-based application, additional languages, new child version, etc., will further help our understanding in Pompe disease and its impact on patients' lives. So now I would like to continue with our preliminary results of the effect of ERT on fatigue. Previous results from the survey has shown that fatigue is a prominent disabling symptom for Pompe patients. And for this particular paper, the severity and prevalence of fatigue was assessed by the fatigue severity scale in a group of 245 international Pompe patients. And here you can see, I don't know, do you see my map? Yeah, okay. You can see here the scores of fatigue, and a score above 4 indicates fatigue, and a score above 5 indicates severe fatigue. And you see here patients are subdivided in their disability level based on wheelchair use or ventilation. These are the patients without any wheelchair or ventilation. And at the other end you have the patients who use a wheelchair and ventilation. And you can see that even the patients who are less severely affected have a score around 5, which indicates severe fatigue. And for comparison, I've also added the scores of healthy controls, and you see that healthy controls have a score about 2.9. So fatigue is a prevalent symptom in Pompe disease, and therefore our objective was to assess the effect of ERT on the severity of fatigue by comparing fatigue severity scores before and after start of ERT. The data was gathered as part of the Pompe survey project, and all patients who were older than 18 years of age were included, and patients who had pre- and post-treatment data available more than 6 months. For the statistical analysis, we used the broken stick method to calculate the course of fatigue before and after start of ERT. So again, the fatigue severity scale, it is a self-report questionnaire, measures fatigue and the severity of fatigue and the impact on an individual's daily functioning, and it consists of 9 items with a score ranging from 1 to 7, 7 indicating most disabling fatigue. And as I mentioned, a score of 4 and higher is fatigue, and a score of 5 and higher is severe fatigue. So this is the fatigue severity scale. I don't know if you can read it, but here I have, I want to show one of the questions. It says, I am easily fatigued, and a patient can check the level or the severity of fatigue that is applicable for them. So, a summary of the results for this part, for this study, 163 adult patients were included, and during the years, 1,174 questionnaires were completed. Patients had a mean age of 50 years, a mean disease duration of 13 years. More than 50% of them were female, and we had 38 US patients participating, and the pre-treatment period was 3.5 years, and the treatment period was 3 years. So at start of ERT, 85% of the patients had an FSS score of 4 or higher, so they were fatigued, and almost 70% of the patients were severely fatigued. So this figure shows you the course of fatigue before and after start of ERT. So you can see here the starting point of ERT, and this is the pre-treatment period, and you see that it somewhat remains stable before treatment, but they are all around 5. And then after start of ERT, they decrease by 0.13 FSS score points per year. So the difference actually is a decrease in 0.15 score points per year of fatigue. So in conclusion, we have confirmed that fatigue is common in adult patients with Pompe disease. ERT significantly lowered the fatigue severity scores, and these are still preliminary, and we need to look at other factors that are associated with fatigue to get a better understanding of fatigue. So now I would like to continue by telling you something about the life expectancy of adult patients. Well, so far there were no data on life expectancy of adult patients. We know that there were survival curves for infants, and this kind of information, as you know, is important for physicians to provide patients with more prognostic information on the course of the disease. So, and of course, to assess if treatment is actually positively or negatively influencing survival, we need to know the survival or the life expectancy of untreated patients. So when you look at the survival or life expectancy of adult patients without treatment, and we have performed an analysis with 286 adult patients with a median age of 48 years, and I will explain more about this curve, and you see here that this is the survival percentage. So 100 survival means that everyone is still alive, and this is the time from diagnosis in years. And you see that for this particular group, after 5 years after diagnosis, 95% of the patients was still alive, and 27 years after diagnosis, this was 50% of the patients were still alive. And this is all on a group level, so again, you should not translate this to individual patient, but it's more to get kind of an estimate of what the life expectancies of adult patients without treatment. So when we look at factors that influence survival, we see that age is of influence, and you can imagine that the older you are, the more likely you are to die earlier. And disability level, also based on a wheelchair or ventilator use, was of influence. And this again shows you a survival curve, and then by disability level. So the upper line are the patients without any wheelchair or respiratory support, and the blue line are the patients who did use wheelchair and respiratory support. And you can see that this is the follow-up time of the patients in years. After 5 years, 97% of the patients who didn't use a wheelchair or respiratory support were still alive, as opposed to patients who used a wheelchair and respiratory support. That was 76%. And furthermore, also the RHS score, so the Rotterdam Handicap Scale score, was associated, and it's actually comparable to the disability level of the patients. So this is all again on a group level. Furthermore, we also compared the mortality of the adult Pompe patients with the general population, and we could only do this for the Dutch subgroup because we did not have information on the general population of all other countries. So we used data from the Dutch Central Bureau of Statistics, and for each Pompe patient we used a match from the general population. And you can see that the Pompe patient had a higher mortality compared to the general population. This is all without treatment. So currently we are working on, we are looking at the effects of ERT on survival of adult patients, and we have performed several analyses to get a best accurate estimate of the effect of ERT. And I will show you two methods. The more crude method, which you can see here. You can see here patients assigned to ever ERT, so without taking into account the duration of ERT, and the patient who never received ERT. And you can see that patients who ever received ERT have a much more better survival than patients who never received ERT. And when you look at the more conservative method, so this also takes into account the duration of ERT of every person, you still see that the patients with ERT have a better survival, although the difference is somewhat smaller. But ERT seems to have a positive effect on patient survival in adult patients. So in conclusion, we have estimated for the first time survival or life expectancy in both treated and adult patients with Pompe disease. Severity, age, and RHS scores were prognostic factors, so to say, for survival. And the Dutch Pompe patients had a higher mortality compared to the general population. And ERT seems to expand the life expectancy of adult patients, but this is still preliminary, and we are also looking at other factors such as severity that are of influence for survival. Well, I would like to thank especially everyone from the International Pompe Organization for getting this study on track and for their continued participation, and of course all of the participants who well, during the years all participated. Thank you.
Thanks, Denise, for this very clear presentation. And now we take some time for questions for either Dr. Krishnani or Dr. Vanderberg or Dr. Gungor. And if you please, you can stay here to take any of these seats because we only have 1, 2, 3 microphones.
I want to thank you all for presenting some very exciting data. I guess I was taken back by your data on looking at the age of symptom onsetting in patients, the age of diagnosis, and then the age of treatment. It expands over a 20-year period. So obviously, Priya's mentioned it and others today that we've learned that timing of therapy means a lot. I was wondering if you might comment on how you think that difference, especially seeing that in the Netherlands, a place that's renowned for their ability to diagnose these patients, if you think, and how you think that affects the outcomes of the measures that you looked at. Thanks.
Thank you very much for this question. Of course, that's still something we need to learn. But in fact, what I realize is that everything points to the same conclusion, that you shouldn't probably not wait too long with start of enzyme therapy to get the best outcome. And in fact, that's what we saw in the first trials, that's what we saw in the infants, and I think that's also what we're going to see in the adults.
I have a question. My name is George Fox. My son Phoenix has infantile Pompe disease. My question is for Dr. Kishnani. And I just wanted to see if there was any published results or otherwise from the Genzyme comparison study of the high dose versus high frequency. I was interested to hear that.
Sure. So, George, that's a very timely question. We are currently starting to analyze that data. I think one of the challenges of that particular protocol was that there were children as well as adults and different stages of the disease. And so it's sometimes hard then to do collective experience on it. So I think we try and do this more as a case series. But just from the clinical experience that we are having at Duke and at other institutions, clearly there is an impact of higher dose. And I think that the frequency of the dose also seems to make a difference. What we are recognizing, or at least from preliminary work, looking at the biomarker for Pompe disease, it appears that when you do a higher dose, in terms of say 40 rather than 20 twice weekly, the targeting to skeletal muscle seems better, and we're seeing a more downward trend in the biomarker, the HEX4, on the 40 milligrams per kilogram every other week, rather than the 20 milligrams per kilogram every week. So the data is still outstanding, but this is what the preliminary data looks like.
Thanks. Were most of those patients, were they infantile? Did you say it was a mix?
It was a mix of patients, and so we've tried to separate them by infantile versus some of the later onset patients.
Thank you. Thank you for all your presentations.
May I also make a remark to this, to your question? Because indeed, we currently treat a lot of the patients with 40 milligram per kilogram every week. The infants, specifically the infants, because what we saw indeed that in infants the disease is so severe and you easily lose a patient and easily the patient gets ventilator dependent. It's still anecdotal what this does to the patients. You can doubt whether you should use 20 every week or 40 every week. We also have a patient who still does very well on 20 every other week, so there we still have to look for the prognostic factors. But at least I want to mention that for the very first time we had a patient who became ventilator dependent, and in the past we were not able to get a patient off the ventilator, and at least we succeeded to get this patient off the ventilator during the day and get him back on the feet again, at least that he was able to ride a tricycle, and that already I found quite a good result. And also we've seen in some others that life-threatening respiratory infections became less. But still it's anecdotal, and we still need to continue on these type of research.
Thank you.
I see two other questions. The one came behind you, Nim, and then it's Dr. Raven. Yeah, yes, please.
I was struck by the improved response in women, and I wondered if this had been observed in females in any of the populations, and if you could speculate about a mechanism.
So I stand up now. This is not completely sure. We were indeed surprised to see that women responded better than males, and it's pure speculation at this moment. I mentioned it during my talk that it could be that the lean body mass in men is higher, so we have a higher muscle mass. And for example, also the fibers are larger, so you could also imagine that if the enzyme has to hit the mannose-6-phosphate receptor, that there's more distance to the internal side of the fiber, but also that maybe there are less mannose-6-phosphate receptors per area on the fiber that might be related, but it's speculation, and I think more research has to be done.
Dr. Raven, wait for the microphone. Yes, thanks.
So you based your conclusions or preliminary conclusions about the dosage and the regimen which you use for patients 20 versus 40 or every other week as opposed to every week. And so you based your conclusions on the clinical outcome, obviously, but what is the scientific basis for this? How long the enzyme survives in muscles?
Yeah, of course we didn't base it pure on the clinical thing. We based effects this decision on our long-standing experience in basic research.
What do you do with that?
I think yeah, okay. And one of the things that we found in the past, that we found in all the experiments that we did in mice over time, that you needed at least 20 milligram per kilogram to clear the enzyme, or to get the enzyme in the muscle. And if you give a lower dose, the enzyme does not end in the muscle. And probably that is caused by the fact that liver and spleen, for example, are organs that are very easily accessible by the enzyme. They are in the bloodstream, and it's known, for example, in Gaucher's disease that you need low doses of enzyme, and they get into the macrophages in the Kupffer cells. But if you want to reach the muscle, you first have to cross the endothelial cells, the smooth muscle cells, the fibroblasts, and then get into, finally, the muscle. So relatively a small proportion of the enzyme finally gets to the muscle. So you need a certain critical concentration probably in the plasma to get there. And I think this is one of the major reasons. And in fact also, I want to go back to our first studies in humans. We started there, and it was we chose the dose based on experiments in mice. And we started in infants with a dose of 15 or 20 milligram per kilogram based on the surface area. And then we saw that in these patients, some deteriorated despite the start of the therapy. And that was reason for us at that moment to increase the dose to 40 per kilogram, and also on base of the activities that we measured in the muscle tissue. About 24 hours after an infusion was given, we did a muscle section and we measured the activity. The third reason why we think that you need a higher dose is the internal turnover of the enzyme. Of course, you have the enzyme is given intravenously in the blood, and then it disappears quite quickly from the blood. I think after 24 hours you don't have any enzyme in the blood anymore. But then we know from experiments in fibroblasts and in cultured muscle cells that once the enzyme is in the lysosomes, it has a half-life, alpha-glucosides, of about 6 to 9 days. And we made some calculations together with Arnold and hospital pharmacy how these curves get. And then what we concluded is that probably the time between two infusions of 2 weeks might be too long, and that it's better to give it every week for some of the patients. And this is the reason. So it's a combination of factors, so not only the...
Dr. Kishnani, you want to add to this?
I think actually a lot of our work is based on the preclinical work and beautiful work done by Alison McQuay at Genzyme, where she's done comparative doses. And I think where we stand today is still with very limited understanding of the appropriate dose and the individualized nature of dosing across the lysosomal storage diseases. To date, we have very limited work on MPS, on Gaucher, including on Pompeii. I think one other part that we have overlooked is that what we have seen is that there are some patients who, despite I'm really not having a good technical day today. But just to continue, another part that we have seen is that as we looked at the clinical trials data and our clinical experience, I think the role of immunogenicity has to be recognized, and just increasing the dose sometimes for a response is not really the answer, because if you are going to trigger an immune response, by giving more enzyme, you're actually going to trigger more of an immune response. So I think first understanding the antibody status of the patients is very important even as we move along with a dose response. So Nina, I think we've gone around your question but not completely answered it. And maybe Alison is here. I don't know if we want to have Alison answer that in a moment. Alison, would you like to answer? From the preclinical.
You want the microphone? Yeah. Or are you going to include it in your presentation?
It's not in my presentation.
To save some time, you know.
So I can just speak. So I'm Alison. I'm from Genzyme. I'm in the preclinical development group at Genzyme. So I can answer the dosing question from the work that we did looking at the effect of the enzyme in the Pompeii mouse model, which is how we developed the dosing regimen that we ultimately tested in patients. So in the mouse model, when we give the enzyme to the mice, we're able to look in the tissues of those mice and see how long does the enzyme last in the skeletal muscle. And from those experiments, we saw that the half-life of the enzyme, or how much enzyme, or how long it took for half of the enzyme to disappear from the muscle, was between 5 and 8 days in the mouse. And then the other important component to this, though, is not just how long is the enzyme there for, it's how long does it take for glycogen to start to reaccumulate. And so we did some experiments where we looked at the glycogen kinetics of reaccumulation in the skeletal muscle, and we saw from those experiments that after we had treated the mice, that we saw that the enzyme kept those glycogen levels down for quite a long period of time, and we saw that it didn't start coming back up again in the mice until about 21 days after the dose. So somewhere between 14, 21, 28 days, we started to see the glycogen come back up again. So on the basis of those experiments, we came to the conclusion that dosing every other week would allow enzymes still to be present in the muscle after 14 days, and we also hoped that it would keep glycogen levels down and prevent the reaccumulation. So that was the basis of the human dosing that was initially tested.
Can I ask you one other detail?
Yeah.
The level of dosing in that particular experiment?
So we did a dose response. So we looked at 20, 60, and 100 mg per kg. For the half-life experiment, we looked at 100 because in the mouse we do have to give the mouse more enzyme. And then for the glycogen, where we saw the nice clearance of glycogen in the mouse, it was at the high dose, the 100 mg per kg.
Yeah. Because that makes a difference, because the patients don't have any activity. Then you give a very high dose, you shoot it up.
Yeah.
But with a half-life of 3 days, it simply means if you're at this level, within 3 days, you are down here. And 3 days later, you're down to what you actually had. So there, in that type of experiment, the dosing is extremely important.
Yeah,
So the answer is we don't know exactly, and the doctors look at the patients and other people think about it, and we try to be what's best for all, something like that. Other questions?
So is there any data in humans? I'm not so sure I believe the mouse data, given that there's so much patients are so heterogeneous. I wonder if there's a difference in muscle half-life of the enzyme. I mean, how variable it might be from patient to patient, especially given the variable immune response. Do you think the immune response plays a role in muscle half-life of the enzyme? Is there a mechanism that can explain?
Shall I try to answer? There is no straightforward answer. But I think if you think about mice are different from man, yes. But biologically, if you think about what is an enzyme structurally and what is a muscle cell structurally, there is not much difference, I think, between mice and men. So my hypothesis would be that if you have data on the mice, they probably apply also to the human situation. But for knowing, you have to measure it in the human situation, but that would actually imply that after a dosing, an infusion, you have to take muscle biopsies every 2 days, and we don't want to do that.
Given the variable states of disease and how much autophagy is present, I mean, if it gets diverted to these autophagic vacuoles, it would not be very stable in that pH environment.
Yeah, that makes it even more complicated, and all these complications make it actually impossible to predict, and we can just make a rough estimate. And the estimate is indeed half-life of about
maybe
6 days, 9 days, I think.
Does Amicus have any data? I know that that's something they're looking at to see if they can prolong the half-life of the enzyme in muscle.
To lengthen.
I don't know if they have any human data. I know nobody seems to have human data.
Maybe we'll have the answer later after the presentation from Amicus. That's what you said. Is that okay, or?
With me?
No. I mean, is this question now fully solved, or is there still something pending?
It's pending.
It's pending. There is maybe a gentleman who can help out.
No.
Sorry.
No, I have another question, but I'm not sure.
I was wondering whether you have human data in tissue that are not muscle, but that you can use as a surrogate for muscle, for example, PBMCs or stuff like that.
Cultured muscle cells, that's the best we have.
So, but in humans, nobody has done skin biopsy.
Cultured human muscle cells. And skin is again very different, because when cells start to divide, one cell makes two, and that makes the level of enzyme drop by 50%. So it's a very complicated thing, but I think we come close with an estimate of 7 days for the time being. I can't make it more accurate, I'm sorry. Dr. Annie, yes please.
Coming back to start, ERT, in your opinion, what will be the indicators of start, the age?
I think that's, of course, a very complicated question. What we currently do, and I think we need to develop with all of us, with all the doctors that treat the patients, definite guidelines, and that also will become easier when we learn more. What we currently do is that at least the patient has to have symptoms of muscle weakness and or respiratory problems. Yeah, that's what we currently do. But then when I look at the patient population that we actually start, most of the patients really have problems with their daily living, and maybe we're still too conservative, but we have to find out in the future. And it also has important implications for children, because that's what I realized is if you once start a therapy, you do it for your whole life. And then you have to do this therapy every other week, and it has an impact, for example, in children, on their school, and then you think now they're growing, and maybe their muscles grow, and maybe they become a little stronger. It's very difficult, especially in children, when is the right time to start, and especially, of course, not the children who have clear symptoms, but especially those, because we have a growing number of children, for example, with the IBS mutation. And they come because of the stumbling, and because more people think about it maybe, and then it's difficult to decide exactly when to start.
Thanks.
If I could comment on that, we have Dr. Chen here from Taiwan, and they've got very good data from the newborn screening program. And I think that even starting at birth for some of the infants is already too late. I mean, if you start looking at the muscle biopsies in some of these infants, there's already significant involvement. And I think we are still at a stage where we don't have a good non-invasive biomarkers, or we are starting to understand the role of biomarkers, because waiting for clinical symptoms sometimes I think is already too late. And I think from the data from the newborn screening program in Taiwan, they have identified a group of late onset patients who have now been put on therapy based on clinical symptoms which are extremely subtle, but which would not have been picked up if we had really waited for for these patients to come to the clinic. Dr. Chen, do you want to comment on this for a moment? Maybe in the afternoon session, yeah.
It sounds like we have just enough time for one more question.
May I make one remark? The remark that I made was, of course, not meant for classic infantile patients, because you should start them right away. Don't wait a minute. Yeah?
Yes, my question was hinting more to late onset patients. Okay.
More questions? Okay. Yes, please.
I just think this whole antibody story is very confusing, which I'm sure is confusing to a lot of people. I'm just wondering, is it the antibodies themselves? I mean, it's clear in some cases if they're neutralizing antibodies that they're going to have a role in treatment response. Are we looking at the right thing? Is it really, are antibodies just a marker for just a general immune reaction, and we should be focusing on some other immune mediator, or is it the antibodies that we should really be concerned? Do you have some insights on that?
I'll be doing a talk on this tomorrow, so I think we can try and address it tomorrow in the interest of time. But I think it's a marker, and we have to look at markers of inflammation and many other factors, but clearly measuring antibodies in vitro is quite different from what's going on in vivo, and so showing the correlation. But I think we can address this more tomorrow.
Yes, please.
I have an adult onset Pompeii. I was wondering, has anybody ever looked at, since this disease is genetic that we receive from our parents, has anybody looked at, our genealogy to see if we all come from some same place? Maybe go into Ancestry.com or something and, find out if there's some common link between all of us. It seems like the Dutch have done a lot of work. Is that because there's a lot of Dutch patients, or is it just because it was discovered there? We all have some connection with?
Is this something for you, Arnold?
Yeah. It's a short answer. We look at DNA variations, and they are predictive of where people come from. And there's a certain mutations, we do see it all over the world. And it's not only this single abnormality in the long gene, but the whole gene, letter by letter, is identical. So that does mean that this particular mutation has been spread around the world, probably from what we call a founder, or a few founders. We have seen another particular mutation in the Netherlands and in the south of Italy. And that were the Vikings traveling around the world. They went to Italy. And we have seen another mutation originating in the north of Africa. And Dr. Raven and Dr. Plotz have worked on it. It's a fantastic story. Because in those days, there was slave trade. So the people migrated from the north of Africa. They went to the coast, the west coast. And then they were shipped to the Americas. And this mutation you find in the African Americans, North American, and the South Americans. And also it went to Saudi Arabia, and we have found it back in the UK, people that moved from Saudi Arabia to UK. And we have found it in the very south of Africa, South Africa. And that were people that were living in the north of Africa. They went to the coast and they walked all the way, down to the very far south tip of Africa in about 100, 200 years. And I think that was a fascinating thing we did, and I'm still fascinated by what came out. And I think, yeah, that was the thing. So there are connections, but also there are 400 different abnormalities in this gene, which is only 3,600 somewhat letters, 400 abnormalities. Yeah. If there are no more questions here for the audience, then we have coffee, and of course you can always go to the people. Thanks very much, and also thanks to the first two speakers. I won't try to restrict the coffee time to 15 minutes, so you can also come in with the cake and the coffee, and then finish it here if you feel hurried. Thank you. And it's in alphabetical order, because you always have to be very careful. So it's Amicus, it's the A, and then it's Biomarin, the B, and Enzyme, the G. And the first speaker, I think it was going to be presented Amicus by Dr. Patel. And she is Director of Patient Advocacy.
Good morning, everybody. My name is Neeta Patel, and thank you, but I got promoted to being a physician. I'm not a physician, I'm a nurse. I've been a nurse all my life, but in LSDs, I've been a nurse for 20 years, taking care of patients with Gaucher, Fabry, and Pompeii, as well as MPS I. So I have a very strong bond with patients and love working with patients. And after working in the clinical setting, I decided to further my interest in research, and now I'm working at Amicus as a patient advocate. So let's get started. Today on the agenda, I'm going to give you a quick overview of Amicus, the company, and then talk about patient advocacy and what we do at Amicus within our team. And then Dr. Matthew Adara, is going to take over and talk about our clinical data. So we're going to start with the focus on developing, we're going to start talking about Amicus and when it started. In 2002, pharmacological chaperone technology was started out of Mount Sinai School of Medicine. In 2005, Fabry disease was our primary program at that time, and AT101 was the compound that we were first started patients treated with Fabry disease. In 2007, Amicus became a public company. 2009, we registered our phase 3 trial in Fabry again because that was our lead program. Last year, we collaborated with GSK. It was a great move for Amicus because GSK wanted to enter the space of the rare disease, and they approached Amicus that has the expertise in rare disease, and together the collaboration took place, and it's working very well for our Fabry program. We are now starting to do our Fabry program, co-administration program, and it is our lead program, but we will be discussing also our co-administration program in Pompeii, and Dr. Adara will discuss that further. So our key strategic priorities, as you know, and I've said it several times, Fabry was our lead program. We are conducting the 001 study currently, and we're close to ending enrollment, which is a great achievement for us. And we will be ending the enrollment at the end of this year. We are also doing the EU registration for the study. Chaperone ERT and co-administration therapy is a very exciting program for Amicus, and we should be starting to get the phase 2 trial up and running. And now to discuss the Pompeii AT2220, you all know the history about AT2220. We were put on clinical hold. And because the FDA wanted some more studies done, especially in the muscles. We actually did what the FDA wanted. We worked very, very hard. The clinical team really worked hard and got the information for the FDA, and we successfully on March 2011 got off the hold from the FDA, which was really good news. We also have other things that we are looking at, development of diseases in the neurodegeneration area. We've completed and advanced our preclinical proof of concept studies for the AT3375 for Parkinson's disease. And also we're looking at the proof of concept studies for the Alzheimer's program. This is just showing you a graphic slide just to show our programs and where we are. As you can see, the AT101, 1001 is with the GSK, and it's just the Fabry program. The phase 3 monotherapy is close to end of enrollment there. And then we have the Pompeii co-administration program just starting the phase 2. So let's talk about patient advocacy, which is what my love is, and I feel comfortable with. I came to this conference and I am just so amazed with patients, with scientists, with industry, and the collaboration of everybody to be in one goal, and that is to get treatment for patients. And it's just so exciting to see the interactions between scientists, physicians, nurses, patients, and how knowledgeable the patients are. And that's how it should be. You know, we need to take control. I personally have a child with a chronic disease, and it wasn't until she was diagnosed that I realized the importance of patient advocacy and patients actually fighting for their rights and knowledge. And it's great to see this. So I wanted to put that out there first. And how does Amicus do this? And we just don't do this with Pompeii, we also do it with our other programs. You know, we attend regional meetings like this, we attend international conferences, symposias, we interact with professionals, we interact with patients and associations, and try to do as much education and learn and give as much as we can, as much as within the FDA guidelines that we can. And you know, there is always a guideline that one has to follow. How do we communicate? We communicate, we have a great Pompeii Patient Advisory Board. We hold meetings twice a year with that board. It's a group that get together and we exchange ideas, we talk about company updates, they give us the patient's perspective, and that's the tool that you guys can utilize to get more information if needed. So we've been doing that for a number of years. I started that with Amicus when I was there 2 years ago, and now I'm back with Amicus and I'm excited to have the next Pompeii Patient Advisory Board meeting. We also interact and talk to key opinion leaders as well as the coordinators and see if there's an educational need that they have within their groups and maybe help address that need. We also communicate with patient organization leaders using emails, conference calls, company updates. We also provide a Pompeii community update newsletter. We have a confidential database of anybody who wants to get information from us. We mail a copy of our newsletter. You can get an electronic copy. If you are interested in that, there are contact cards out there on the table, and if you fill that out and get it back to us signed, that will allow us to communicate with you. We provide brochures, videos, presentations, and our website, articles for publications. If the patient organization has a newsletter, they ask us for any updates, and we do provide anything that we can for the newsletters. So it's a very active patient advocacy group that we have because we really are committed to the patients. This is showing you a slide of just what our Pompeii study website page looks like. You can go to www.pompeistudy.com or the clinicaltrials.gov for any information on any clinical trials that's occurring at Amicus, or anywhere actually. I just wanted to go over very simply the proposed mechanism of pharmacological chaperones. A lot of people may already know this, but this is a very nice way to show you how pharmacological chaperones work. So here we're looking at a cell, and in the endoplasmic reticulum is where the enzyme is sitting. And if you have a mutation, that enzyme becomes unstable because it's not folded properly, or for whatever reason it's not going to be able to work there because it has a mutation. And there's an active site where you can see where the arrow is. So what happens is, let's see, this works there, it does. So here is the enzyme, and it's not going anywhere because it cannot go there because it's unstable. It wants to get to the lysosome on the right-hand side there. So pharmacological chaperones are then administered, and what it does is actually binds to that site, that active site, and makes that protein stable. So now that it's stable, it is then able to go across the Golgi apparatus and into the lysosome. That's where the substrate is, and that's where it needs to do the work to break down the products. And so that's how, in very simple terms, this is how pharmacological chaperones work. So now I'm going to actually hand over the mic to Dr. Adera, And I'm around if anybody has any questions or would like to discuss anything, you know, I'll be happy to do that later.
Thanks. Professor Reza, how many minutes do I have? 2 minutes? 2 minutes. Okay, I'll try and summarize my presentation then in 2 minutes. I have to say that it was by intention that we called ourselves Amicus. We are the youngest youngest son in this orphan disease group. And so coming to conferences like this, you've got to get noticed. So we are Biomarin and Enzyme, so we are Amicus, and I guess it worked today, as you can see. So we are the first ones online. Now, I'm very briefly going to just give you a brief review of this 80-22-20. That's our pharmacological chaperone for Pompe disease. So as has been said here, we actually did get into the clinic in the year 2009 with this pharmacological chaperone. It was a phase 2 study, and we stopped the study after 3 patients were enrolled in the study. I remember getting a call from the late Dr. Fanhoff telling me that one patient had muscle weakness, and then I asked him, how about the other patients? And he said they were fine, and then 30 minutes later he called me and said they had called one more patient, and the patient said that they had muscle weakness. And I said, please stop the treatment immediately, and I got support from my company, and of course that then became an official FDA hold. Now, we were really perplexed because we had done a lot of studies in animals as well as in healthy volunteers looking at the pharmacokinetics of this compound. And we did have a pretty good safety profile. We had actually dosed it at very, very high doses, 2,000 milligrams every single day for 14 days in healthy volunteers, and in primates, 2,000 milligrams per kilogram for 9 months. We did not see anything. So coming into the clinic, this was a bit of a surprise to us, and it was something that we had to get to the bottom of. And the question that we asked ourselves is this: what then is the gap that remains? And the only gap that remained, and I hope that colleagues at Enzyme, if they haven't done this as well, they'll probably also consider doing this. The gap that remained is that we do know the plasma pharmacokinetics of this drug in human beings. What about the pharmacokinetics in skeletal muscle? Because that's the site of action. And we came up with a plan which we presented to the FDA, and it was agreeable to them. And so we went ahead and did a pharmacokinetic study in healthy volunteers. Now, because I'm out of time, I'm not going to go through all the slides, but I'll just try to hit the main points that we need to discuss today. The bottom line is, based on the healthy volunteer study, and we presented a very strong scientific rationale as to what the mechanism of action was for those side effects that we saw, and we also presented again, a very strong rationale for the ability to be able to monitor these adverse events before they occur. We felt we had very good biomarkers for monitoring these adverse events, and we presented animal data, we presented a lot of in vitro data, everything lined up, and at the end of the day, the FDA removed the clinical hold, and actually we have no restrictions as far as that clinical hold is concerned. So I can tell you that we are very committed to patient safety at Amicus. We have 4 physicians working on this program right now, and none of us is going to compromise patient safety. And that's why it took us this long to get to where we are. The bottom line, though, is that after looking at the data that we had, we felt that it wasn't going to be, we didn't feel comfortable going back into monotherapy, and therefore we began to look at other alternatives of administering this drug. And that's going to be the bulk of my presentation today. So just very, very briefly, this is the study that we did, and I know I've shared this in one meeting, at least where I was with Alison as well. So this is what we did, and I'm very, very fascinated. The question that was asked today is, do we have PK for ERT in muscle? It's an extremely important question for us to answer. As far as pharmacological chaperones are concerned, we do have PK in human muscle. We did PK in rats, and then we said we wanted to do it in humans as well to find out if this actually mirrored what we saw in rats. Were rats going to be predictive of what we'd see in human muscle PK? And what we did here was that this was a healthy volunteer study with 36 patients. And what we did was that we grouped the patients in groups of 3, and we got 2 muscle biopsies within a spacing of 8 days from each patient. And how we grouped them was such that with the 3 were able to build a full PK profile in just those 8 days. It worked very, very well. And I know people have asked me, we are strong believers in core needle biopsy. Most of the patients actually went home without treatment, and those that did complain of pain at the site, they went home on Tylenol. But we got very good yield, so we got 72 biopsies, and were able to construct a curve for 2 doses, 1,000 milligrams and 100 milligrams. And this, let me see if I can show you the result. This is what we saw. So if you look at okay. No one taught me how to use that, so I won't try to use it. But if you look at, we have two curves here, 2 graphs here. One is an inset and the other one is not. So if you look at the one on your left.
It's nice. Your fingers are pointing.
Thanks, Professor Reza. Thank you. I feel really smart now. Okay, so if you look at the one on the left, this is a PK profile that we plotted just using raw numbers. And the red is plasma, pharmacokinetics, and the blue is drug concentration in muscle. It appears as if by the end of the day, even with the 1,000 milligrams, this drug is actually coming down to level. But then when we did a semi-log graph, right there, you can see that it's actually a different story altogether. The plasma actually seems to go down quite well, but the muscles seem to remain up for quite a while. Now, this line here that we drew, that's the IC50, and that's the concentration at which we estimate that about 50% of the enzyme would have been inhibited. So at 1,000 milligrams, we find that the chaperone was high enough to inhibit, to cause significant inhibition of the enzyme. Now, based on that, we then went ahead and did the 100 milligrams, and with those we were able to establish dose proportionality, and we went ahead and did some simulations. And we found that actually we do have a dose that we can use where if you use those particular doses, you're able to go below IC50 in a couple of hours. So we do not consider that inhibition will be an issue here. So in summary, therefore, I know I haven't presented a lot of the slides here, but in summary, we found that 80-2220 is rapidly absorbed. It has a peak plasma concentration of about 2 to 3 hours. So if you use that to actually model your dosing, you might actually go wrong. But you also found that it's rapidly distributed in muscle. But if I speak too fast, please can someone just stop me? I'm still trying to speak English, so I'm not changing to a different language. If I speak too fast, just give me a signal. And then we found, and this I think is probably the most important thing for us here, and that is that the 80-2220 concentrations in muscle exhibited a biphasic decline. The first decline was quite rapid, decreasing about tenfold within 12 to 16 hours. And that was then followed by a slower decline with a longer half-life. So we asked ourselves, what do we do? We had by then done quite a few studies in animals as well as in vitro, looking at the potential for 80-2220 to actually enhance ERT. And the question then was, could we actually do that with myozyme as well? And we proposed a mechanism here. We do know that it's not just endogenous enzyme that is unstable in people with certain mutations, but even the ERT that's actually infused is also unstable. And I think that's known to everyone who's infused it. And we asked ourselves, it is an enzyme, so what would happen if we combine that with chaperone? Would chaperone be able to stabilize it the way it's able to stabilize endogenous enzyme? And so this is the mechanism that we proposed, that if a pharmacological chaperone was given orally, it would combine with the enzyme in circulation, stabilize it, and that would increase actually increased delivery of that enzyme into the tissues and finally into the lysosomes. And if that worked, then you should be able to see an increase in substrate clearance. So we did some thermal denaturation studies at a pH of 7.4, which would mimic what you have in blood. And here we looked at myozyme with or without 80-2220. And just very, very briefly, if you look at this curve, going towards the right, that's more stable. Going towards the left, that's less stable. And briefly, we found that if Myozyme is given by itself, that's the curve that you have. If, on the other hand, you actually give it together at that same pH, 7.4, which mimics what you have in blood, with 10 micromole of 80-2220, you find that its stability increases. The curve moves towards the right. If you give it to the higher dose, the curve actually moves further towards the right, and that stability then mimics the kind of stability that you get in the lysosome at a pH that is much lower, which is 5.2. We then went ahead and looked at residual enzyme activity. So it's not just enough for your enzyme to be stable. So we asked ourselves, what happens then with this enzyme? And the green curve here shows Myozyme by itself. And you find, if you follow it over a period of 25 hours, you find that the activity decreases quite rapidly. And when you combine with 80-2220, and I believe that's the red up there, you find, sorry, the blue up there. Sorry, this was the curves are so close to each other. That's at a pH of 7.4 plus 80-2220. It remains stable for much longer. And if 80-2220 at a pH of 5.2, you find that the stability is still maintained quite high. And then we looked also at the folding of the protein. Is it properly folded? And we found again that Myozyme by itself misfolds relatively fast, and again within one day you find that most of it is misfolded. But with 80-2220, again the folding is actually maintained, proper folding is maintained. I'll respond to this if there are any questions later on. And this again just shows you more or less the same thing, activity with or without 80-2220 in blood. Now, we then moved on from the in vitro studies, and there are a lot of other experiments that we've done. So these are just a summary of some of the representative experiments. We asked ourselves, would this also then occur in vivo? And in vivo, what we did here is that we looked at GAA knockout mice and looked at enzyme activity with or without 80-2220. The blue here, that's just the, where's the vehicle? The black here is just the vehicle. That's saline, so there's no 80-2220 in plasma. But the blue, you find that should be water plus recombinant human GAA. So that's the effect of GAA by itself. And you find that if then we give increasing doses of 80-2220, you find that this enzyme actually maintains its activity much or rather longer in blood compared to just ERT alone. I'd like you to look at this side here where we calculated the half-life, and the half-life of recombinant GAA in our experiments was about 1.4 hours, but with 3 milligrams per kg of 80-2220, the half-life was actually 1.5 times longer, and with 10 times that dose, the half-life was twice as long. And these are doses that are actually achievable in the clinic from what we have seen. The next question we ask ourselves is, ERT is not given as a bolus infusion. The previous graph I showed you was as a bolus infusion of ERT through the rat tail vein, but ERT is given as an infusion, not as a bolus injection. So we went ahead and repeated the experiments as an infusion, administered over 1 hour, and we saw the exact same results. The next question then we asked ourselves is, all right, if activity is maintained in plasma or in blood, what does that do to tissue levels? Is there an increased uptake in tissue? And here, this GAA knockout mouse, again, were treated with recombinant GAA with or without 80-2220, and then they were sacrificed, and we looked at GAA activity in the quadriceps, triceps, tongue. We looked at the heart. Actually, we looked at a lot of tissues, but the story was maintained that untreated, which is the white, sorry, my mouse will not the white there, you see very little activity. Of course, with recombinant GAA, you see an increase in activity, and GAA plus 80-2220, you see an uptake in tissue. So that we know. The next question then we ask ourselves is this: does this uptake then translate into increased substrate clearance? And those are the results that you see here, again in mice, where, if, again across all tissues, the first graph here is just the vehicle, then the blue is ERT, and then the red and the green are increasing doses of 80-2220 plus ERT. So again, you're saying that the story maintains, it's consistent across the board, that activity is increasing, tissue uptake is increasing, and glycogen clearance is also increasing. The next slide that I'd like to share with you, and this was almost like a coincidental finding, although I'm aware that this has been replicated in at least 2 other sites. So in this case here, we found that animals that were administered Myozyme, they ended up dying after about 8 injections, 8 infusions. But coincidentally, we did find that those who were administered Myozyme together with 80-22-20, actually there was an improved survival. So if you look here, the first graph set of bar graphs here that you see, that's the 3rd infusion. So at the 3rd infusion, you find that most of the mice are still alive, but as you go on to the 4th, 5th, 6th, 7th, and 8th infusion, you find that the mice that were administered 80-22-20 alone, by the 8th infusion, all of them are dead, but the ones that were co-administered are still alive. And we find that when you give a higher dose, actually the survival of 80-22-20, the survival seems to be increased. So there seems to be a dose-dependent response here. I will not go into what we consider to be the mechanisms of action there, but it's something that we are looking into as we speak. All right, so we moved on from there. Now that the clinical hold was removed, and we asked ourselves, okay, if you cannot go back into the clinic with monotherapy, can you do anything to improve the therapies that are there? And that's a study that we currently have here on the screen, and I'm glad to say that this study is open and it is enrolling. It's a phase 2A proof of concept study. We want to see whether what we saw in animals is actually repeated in Pompe patients as well. And in this study, we'll be comparing recombinant GAA, that's Myozyme or Lumizyme, with or without 80-22-20, and looking at plasma activity. So it's a dose-escalating study with 4 cohorts, starting at 50 milligram dose and going to as high as 600 milligram dose. And between those dose escalations, we'll have a 2-week period during which we have a DSMB that will look at safety and confirm that it is safe and okay to continue. We have safety markers that you're looking at here. One of them is CPK, or creatine kinase, which is an enzyme that you see increasing if there's muscle injury, lactate dehydrogenase, alkaline phosphatase. We'll also look at HEX4, which you may be familiar with, as well as infusion-associated reactions. It's enrolling both males and females, ages 18 to 65. And the really interesting thing that you're doing here is that it's not just the plasma activity that you're looking at. We'll actually have 2 muscle biopsies again. But now we feel more confident. We have experience with these muscle biopsies. We have great sites that actually we are working with, and great training that will take our physicians through as far as these muscle biopsies are concerned. The muscle biopsies are not punch biopsies. This is a mistake. These are co-needle biopsies. We will take a muscle biopsy with ERT 7 days after ERT alone, and then we'll take another muscle biopsy 7 days after ERT plus 80-22-20. And what we are hoping to see is not just an improvement in plasma activity with 80-22-20, but also an increased activity of the enzyme in the muscle 7 days later. Thank you.
Thanks, Amicus, for this very nice presentation. Shows where you stand and what we can expect in the future. Next speaker, Biomarin. Never always called.
Very good. Thank you, Dr. Reuser. And ladies and gentlemen, I also, as with previous speakers, want to say thank you very much. It is a privilege. I repeat all of what prior speakers say, and to be able to stand for the first time here for Biomarin, to say thank you very much for having me. I'm going to talk today about why Biomarin is excited about our molecule BMN 701, a little bit about the company, and some of the basic research that went into our decision to move forward with this product, and then tell you a little bit about the trial that's ongoing here at Biomarin. Is it just a single flick?
Yeah.
Okay, good. So at Biomarin, you can see our current pipeline. We have 4 products in the clinic, or excuse me, commercially available now, 2 for MPS diseases, MPS 6 and MPS 1. Those are Naglazyme and Aldurazyme. Kuvan is now commercially available for patients with PKU as well, and Firdapse for LEMS. So we have experience that's a wide experience now in rare diseases, and we are actively pursuing additional products. Currently, Galanest is in phase 3 in an actively enrolling study, a global study where we'll have approximately 40 sites in 20 countries, and we're very encouraged with phase 2 results for that product. In addition, PegPal is a product that has promise for patients with PKU who are resistant to Kuvan, and that study is in phase 2 and moving along well. BMN 701 is the product I'll talk about today, and we have other products that will expand our horizons into cancer as well as immune diseases and other areas. So at Biomarin, we're a company of now over 800 employees with worldwide facilities, and we are very happy again to be presenting here today. So we've talked a little bit, and I want to thank the prior speakers for providing background on Pompe disease, but we haven't seen yet a picture of a muscle cell, so let me show you initially what a single fiber of a muscle cell looks like. And you can see some of the components here showing up, including, if I can get my arrow to function, that lysosomes are initially in normal cells very small particles, but as they begin to accumulate glycogen as the disease progresses, they enlarge, and ultimately you can see these muscle cells become very abnormally engorged with these increasingly large lysosomes that fill with glycogen, and its term of glycogen storage disease becomes apparent when one looks under a microscope. And then finally, these lysosomes begin actually deteriorate to the point where this bag of enzymes bursts, and there has been referenced that these lysosomes are acid in their environment. They in fact contain enzymes that are highly destructive. They're destructive because their purpose is to take up debris and all of the old products of the cell that need to be taken to the garbage dump and disposed of. And what happens, of course, when you have this mechanism that's a highly destructive mechanism, and again, I'm losing my mouse, but you have what is a very tightly controlled lysosomal mechanism where you have these very highly destructive enzymes suddenly or over time released into the cell. Suddenly you've got a destructive process, and you end up with a ghost of a cell, a ghost of a muscle cell, which doesn't work and ends up ultimately becoming replaced with fibrous tissue and fat. And in the end, you have muscle that is non-functional and weakness. And those are result in the manifestations of skeletal muscle weakness, and in infants, of course, cardiac weakness, and adults, skeletal muscle weakness and respiratory muscle weakness. This is a picture of a cell and cartoon, and over here is our little lysosome. And we had a wonderful analogy earlier to say that if this was a lysosome, the cell would occupy perhaps all of this building, or perhaps some significant portion of San Antonio. But the challenge that was met by some of the researchers that met this really remarkably difficult task was to get this molecule, recombinant human GAA, the acid alpha glucosidase molecule, which in certain terms is in itself relatively large. If you take some of the drugs that you take, aspirin or some of the other small molecule drugs, GAA is just huge by comparison. So you've got to get this relatively large molecule into this lysosome, and it's a long journey, a long and complex journey. And there are some scientists here who could tell you much more about that, but it is not a simple task to accomplish. But the way it is accomplished is by virtue of the fact that there is this P on the outside of the GAA molecule, and this P is a phosphate. And as it turns out, on the outside of our cells, in particular muscle cells and many of the cells of the body, there is a mannose-6 phosphate receptor, and the phosphate hooks into that receptor nicely and is taken up into the cell. And I sure wish my mouse would work better, but maybe I can do it here. But at any rate, that green crescent hooks onto the phosphate. The receptor is taken into the cell. As you can see, it's enveloped, and it's trafficked or brought into the cellular process and eventually brought into that yellow lysosome. So it would be wonderful if that happened 100% of the time, but as it turns out, rhGAA, which is commercially manufactured and sold by Genzyme as Myozyme or Lumazyme, doesn't have as much of that phosphate on the outside of the molecule as one would hope. And if you look on your right-hand side, you can see a graph showing some data from the mouse Pompeii model. And we heard earlier the reference to the fact that when you give increasing doses of this drug to the mouse, and we also heard about increasing doses given to infants, you can see that at the 20, 60, and 100 milligram dose levels, and I'll try once more with my mouse, this mouse, that you get improved results, improvement represented by decrease in the amount of glycogen seen in this quadriceps muscle with increasing dose of drug. So we know that if we can give more drug, we can get better results. We also heard earlier today that among the strategies that are being employed to improve the results with the use of recombinant human GAA are the hook. Can we make a better hook in order to get more rhGAA into the cell? And many people, or several of the people who are working on this, have tried to get more of this mannose-6 phosphate onto the rhGAA. So Novozyme is a company that tried to get more of this mannose-6 phosphate onto the protein by a chemical process known as enzymatic addition. If you can get more phosphate on there, more of the phosphate will hook onto the receptor, and more of it will be taken up into the cell, more of it will get into the lysosome, more of it, of the enzyme in the lysosome will digest the glycogen, and more of the glycogen will be removed from the muscle, and more of the muscle will be functional. At Genzyme, there's currently a great deal of activity in getting neo-GAA into the clinic. Genzyme has found a way to put more of the mannose-6 phosphate onto their molecule, and the hope is that by doing so, they will get more of the enzyme into the lysosome and better results. At Biomarin, we had a product in development by which we also were working on a way to get more of the rhGAA into the cell. But this is when we learned of a company named Zystor that was working on a technology known as glycosylation independent lysosomal targeting, or GILT technology. Now, this is a complex concept, but it really is basically a hook. And the hook is that if you look here, you see P's, these are phosphates, and you see a crook, which is a hook, and this represents the place where mannose-6-phosphate is taken up on that cell surface. This is that little green crescent that you saw on the cell surface earlier. It turns out that a peptide, IGF-2, you'll see there on the left-hand side of the crook, is not a glucose or not a glycose. It's independent. It's glycosylation independent. It's a peptide. It's insulin-like growth factor. And it turns out that it binds at a very close spot on this same receptor, only it binds quite a lot more tightly. And in addition, it is present or in this molecule on every single molecule. So as opposed to myozyme, where the phosphate is not present on as much of the myozyme molecule as one would hope, the GILT tag, this IGF-2 tag, is present on every single molecule and provides the opportunity for every single one of these molecules to bind and the opportunity for every single one of these molecules to be brought into the cell and brought to the lysosome. So the binding is independent of the presence of mannose-6-phosphate on the molecule itself. Here's a cartoon showing the molecule. This is the RHGAA. This is the business end. This is what processes the glycogen and helps to remove it from the muscle. And over here is the IGF-2 tag, which allows it to hook onto and be taken into the cell and carried to the lysosome. And here are some of the data which show why we are excited about BMN 701. And let me see if I can explain this and show on the x-axis here that one has increasing concentrations. You just put more drug in the test tube and show that along the vertical axis here, you are showing how much of the drug binds onto a receptor that is actually the receptor on the cell surface. And on the green and red lines, you can see the green line is myozyme and the red line is the GAA enzyme, that the binding occurs at a level that requires a great deal more of this substance. You have to put in 146 nanomolar to get full binding, whereas what was Xystor's drug, and now is, since Biomarin acquired Xystor, is now BMN 701, is fully bound at a far lower concentration. 30-fold less BMN 701 is required in order to fully bind the receptors. Earlier, it was also mentioned that there may not be as many receptors on muscle cell surface as there are on other cell surfaces, liver or spleen, and that one of the reasons why not enough molecules get into the muscle cells is because of the relatively limited or reduced numbers of cell receptors, mannose-6-phosphate receptors on muscle cells. You can also see that this blue line for BMN 701 rises quite a lot higher than the graphs for myozyme and wild-type GAA. Well, we have not shown our hypothesis yet to be true, but our hypothesis is that more of the BMN 701 is bound, that this blue line goes higher, perhaps because IGF-2 is known to increase these cell surface receptors. So we are hypothesizing that IGF-2 may increase the number of receptors on the cell surface and may allow more of this molecule to be taken in. Here are data from the Pompeii mouse model, and what you're seeing in heart, what we do is give myozyme to these Pompeii mice, and 2 weeks later sacrifice the mice and measure, in this case in heart, the amount of glycogen that it remains. And you can see that for 12 and then 20 and then 60 milligrams of myozyme, there's clear reduction and removal, or relatively full removal of glycogen from heart. And at 1/5 the dose, 12 milligrams per kilogram, by comparison to the order of 60 milligrams, you have to look at those error bars in order to see that these are similar doses. That at reduced doses, comparatively reduced doses, BMN 701 clears glycogen by comparison to myozyme. This is data from the diaphragm, obviously a very important muscle from which it's necessary to clear glycogen. And again, by comparison to 12, 20, and 60 milligrams, you can see that 4 milligrams, 12 milligrams, and then 20 milligrams of BMN 701 are effective at clearing glycogen. So again, this, if you look at the top of this error bar for 12 milligrams, is similar to the higher dose of myozyme. And in fact, these error bars for 12 are cross the error bars for 60 milligrams of myozyme. And these data in the quadriceps of the Pompeii mouse model are similar as well. So we are hopeful that these mouse data may translate into human data, and that BMN 701 will be effective in clearing glycogen in humans. Here's the progress of the Biomarin Pompeii program. Biomarin first acquired Zystor and the development program in August of 2010. We expanded the trial from 10 to 20 patients when we took over the program. And in addition, we implemented an extension phase study so that patients treated in the 001 trial will be able to go on and receive drug on an ongoing basis after completing the first 24 weeks of therapy. Treatment for the first patient was begun in January of this year. And in addition to approval, we now have regulatory approval to initiate trials in US, UK, with additional approvals pending in Germany, France, and Australia. Plans for scale-up of manufacturing are in progress as well. The POMS 001 trial is now up and running, and you can find details on clinicaltrials.gov. The study will enroll approximately 30 late-onset patients. The administration of the drug is every 2 weeks for 24 weeks, and I mentioned the fact that there is extension phase treatment available to all patients who enroll in POMS 001 and who qualify for continued therapy. There will be 3 dose cohorts, 3 patients at 5 milligrams per kilogram, 3 at 10 milligrams per kilogram, and then in assuming that there are no significant adverse events that prevent increasing dose, there will be an expansion to 20 patients at 20 milligrams per kilogram. Primary endpoints will be safety, measurement of antibodies, pharmacokinetics will be measured, and the measurement of activity or efficacy will be measurement of muscle biopsy glycogen and GAA levels, measurements of forced vital capacity, as well as maximal expiratory and inspiratory pressures. MVV is maximal voluntary ventilation, which is how much air one can breathe in and out as fast as possible within 15 seconds. And endurance and strength testing will be performed by 6-minute walk test and quantitative muscle testing. Patients must be greater than 13 years of age. They must not have received prior treatment with enzyme replacement therapy. They must be ambulatory, have genetic demonstration of Pompeii disease, and have greater than 30%, but less than 50% forced vital capacity, or demonstration of reduction of forced vital capacity when supine. Current status, we've enrolled both of our 5 milligram and 10 milligram per kilogram cohorts at this time. In the U.S., sites are up and running at the universities of Florida, University of California at San Diego, Kansas University, University of California in Los Angeles, and are pending approvals and initiation in the cities that you can see. We are expecting preliminary release of data at the end of 2012. This is a painfully slow process, in significant part because of the need to go slow to assure safety of treatment. And again, I mentioned that the 002 extension phase study is open. We have a safety review board coming up for our 10 milligram per kilogram cohort this early December. We have safety review after each 3-patient cohort has completed dosing for approximately 2 months. We'll start 20 milligram per kilogram dosing actually probably early next year. I mentioned drug manufacturing scale up, and that we will have more slots available for entering patients in the first or early second quarter of next year. And at that time, once we have seen safety results, and if we begin to see promising activity results, at that point in time, there may be consideration to enroll RHGAA treated patients. But I think until we see safety, and until we know whether there is reason to believe that this drug has activity in naive patients, we only at that point in time will begin to think about treating previously exposed patients. So at that point, I'll conclude and take up.
Thank you, Dr. Wang, for this update and sharing with us these exciting
years and spend my time outside of Genzyme doing some neuromuscular clinic work still, but we want to talk to you about a few things today. The first thing I wanted to do is just thank all of you for being here, and thank, of course, the AMDA and the IPA, and really everyone that's been involved. When you reflect back to where this meeting was in 2005 to where it is now, I think it's really a story of discovery and a lot of successes. There's also been a few challenges, and I think that as a group and as a partnership, I think we have all grown from that. Certainly Genzyme has learned a lot from the partnership with this group, and I know that we'll continue to do it. And I'm really happy that we have some new partners in the room today that are able to present some data on some additional scientific work, so thank you also. We see this partnership as a privilege, and not only as an opportunity, but as an obligation, both to you and to our company. So thank you again for allowing us to be here today. We're going to talk very briefly about the history of the program, and then mostly we're going to focus on some new research that we'd like to show you and some plans for development of the next phase. I'm not going to talk more about this, but just to say that if I were to talk about it, many of the dots on this line represent people and individual accomplishments in this room that together I think are quite important. And since it's been covered, I just think it's something that this group should always look back on and reflect that the amount of road that's been covered is significant. Of course, I think we've also identified this morning that the amount of road that we need to go down is still pretty long. So we've made a lot of discoveries, but there are a lot more that will need to occur. In regard to providing therapy or Myozyme around the world. You can see the countries in blue. That gives you an idea of where we now have patients receiving therapy, and so we are working to get to those patients who are in isolated areas or that we haven't been able to reach. And I just wanted to give you an update as to where we are, and we continue to work diligently with patients and governments and groups around the world to try and provide access. Obviously, we are now a company synonymous with manufacturing and the issues that come along with that. You can see here an example of our Pompeii program, looking at our drive up from 160-liter scale, which was initially designed for development and for research, up through the 4,000-liter scale, which is Myozyme in the rest of the world and Lumizyme in the U.S. We are clearly very committed to this. We have run expansion programs and have grown our ability to produce at the 4,000-liter scale, and we're also looking at our 160-liter scale, which we continue to provide in the U.S. as Myozyme here. Obviously, we don't need to talk much about the clinical heterogeneity of the disease. Those of you that are in this room that have been touched by this disease as patients or even as physicians know this, but it's quite significant. I think that's been a hindrance to our discovery and to our path forward in finding the right therapy for each patient, and that is something that we think we need to continue to focus on. What I'd like to do is just remind everyone in the room that we have tried to study from the earliest onset of this disease through its more advanced stages. That includes in infantile onset patients or patients that have a later onset disease. I think that together with our work with the registry and with partnering with many of you out in the world, I think we've increased I think we've played a role as a community of people that are very focused on this disease, and I think this is where we need to continue to focus on not only the disease, but the right way to assess patients in the clinic, and then, of course, the right treatments and what additions or changes are needed. So there's still a lot more to be done, and this is where I want to have Allison McVie-Wiley come up and tell you a little bit about our work surrounding Neo-GAA and the next phase of our program.
Good morning, everybody. Before I start, I just want to say to Kevin that I also wish that Genzyme had bought Edinburgh Castle, because I do think it would be an awful nice place to go to work to every day. As Tim mentioned, an awful lot of work has been done in this disease over the past number of years. But we do, I think, all of us in this room appreciate that there's still a lot to learn. And there's numerous research efforts that are ongoing at the moment, both within Genzyme and across the Pompeii community, to try and understand this disease more, as well as understand the therapy and what exactly does Myozyme do. And as highlighted here, these are some of the efforts that are ongoing. There is still extensive work, and people are really thinking about the impact of diet and nutrition and exercise in Pompeii disease. As Priya is going to discuss tomorrow, there's been a lot of discussion about antibodies to the therapy and potentially some ways to improve response in some patients by modulating that immune response. Nina and Paul have done a tremendous amount of work in autophagy, and potentially there's an aspect and an area there for modulating the autophagic process in Pompeii disease that could potentially result in better treatment. We also could consider adjuvant therapies, so additional therapies that could be given in combination with Myozyme. And there's been some recent work out of Duke with Dwight Cobrell looking at a molecule clenbuterol that potentially might increase delivery of the enzyme to the skeletal muscle. And there's also potential adjuvant therapies out there that might just generally improve muscle health, which again would be a good thing in this disease. There's also some work ongoing at the moment on substrate reduction therapy. So try to approach this a different way, try to stop the glycogen from accumulating rather than trying to clear it. And I think, as we'll hear tomorrow, there's an awful lot of work that's been done on gene therapy for Pompeii disease. And one of the aspects that we're looking at is this improved targeting to the muscle lysosomes to potentially improve glycogen clearance. So when we think about a next generation Pompeii treatment, what would the target profile of this look like? And the first and the most important thing is that we would strive to have a greater, a better, more consistent efficacy, so a better response across all stages of the disease. That's the primary objective of this program. We also would hope that it would have a similar or potentially improved safety profile. And I'm sure many people in this room would agree that it would be good if it was more conveniently delivered, if the infusion could be shorter, if we could potentially do something to help there. So the first step for us, and the first step for many people in thinking about a new approach, or a second generation approach for Pompeii, is to consider the pathophysiology. And I think we all know this: the enzyme is missing and glycogen accumulates in the lysosome. We then need to consider, what do we know about the mechanism of action of myozyme? We know that myozyme binds to the M6P receptor. We've heard that this morning. It gets internalized, gets to the lysosome, where it's then able to clear glycogen. But we also need to consider what we understand that's going on at the cellular level to what's going on at the whole muscle. And we have an understanding through muscle biopsies and being able to visualize the muscle as to what the process is, although we really don't have a good understanding of the exact process of how these muscle cells change. But we do know that in the early stages of the disease, the cells contain these small lysosomal bags of glycogen, and then as it progresses, these expand. The glycogen starts to spill out of the lysosomes into the muscle tissue, and then it starts to damage that muscle tissue, and at that point clinical symptoms become more significant. And the end stage of the disease, unfortunately, we know that at some point in some cells the muscle fibers are completely destroyed, and that they are most likely replaced by fibrosis or fat. And at this point, we know that no enzyme replacement therapy is ever going to help a cell that has got to this stage. So our hope, and we believe, that myozyme prevents cells from progressing to that end stage. But our hope is that we could do that better. We can do it more quickly, and we can prevent more cells from getting to this end stage of the disease. So our development strategy is that, as mentioned, we know the M6P receptor is integral in delivering the enzyme to the skeletal muscles. Myozyme itself has what we say 7 glycosylation sites. So what that is in the protein itself, there's 7 parts of the protein where this sugar is attached to it. We know that, however, there's only one of those sugars that contains that mannose-6-phosphate that's so important to get into the cell. So our hypothesis is to take that molecule and chemically synthesize the mannose-6-phosphate and attach it to those sugars and effectively decorate myozyme with more M6P to hopefully target it better into the muscle cells. And this shows a picture of this. So this is a picture of myozyme. All of these dots are all the different molecules that are inside the protein, and these green dots are representative of the sugar molecules that are attached to myozyme. And you can see that the red, I'm not sure this cursor is, oh, there we go. This is the mannose-6-phosphate that's present in myozyme. So you can see that it's not there to a huge extent. And what we believe that we can do, and what we've shown that we can do with our new molecule, is that we chemically synthesize a linker, which is shown in this blue, and it allows us to link more of this M6P onto myozyme. So you can see the decoration of this molecule with the M6P molecules. We then, and we have done for the past couple of years, we've put this molecule through our research and development pathway to try and get it to the clinic. So we've done extensive in vitro, so that's in a test tube, and analytical testing of this molecule to really understand the structure of it. We've looked at how it functions. We've been able to characterize the sugars that's on there to make sure that the structure is correct. We've looked at how does it get into the cells, and we've looked at how does it process once it's in the cells. We then have moved on to in vivo testing, so in the Pompeii mouse model developed by Nina at the NIH, we've been able to look at glycogen clearance, the distribution, pathology, and most importantly safety, because this is a new molecule, so again we have to go through the process of assuring that this molecule is safe. And then we move on to clinical testing. So some of the results that we have, this is an experiment where we just take the enzyme, we put it onto muscle cells on culture, and we look to see how much of these muscle cells, or how much enzyme is taken up. And the green line is the neo-GAA, and you can see that much more of this enzyme is taken up into the muscle cells. We then look to glycogen clearance, and this is where we have the Pompeii mice. We administer them enzyme every other week for 4 weeks. And you can see if we look at the 20 mg per kg dose for Myozyme, we see modest clearance in the heart after this. Remember, this is just 4 doses. But you can see with our new molecule, at 20 mg per kilogram, we see significantly better clearance. And we see a similar result if we looked at other dose responses. And you can see the pathology at the bottom. You can see the blue or the purple colour in the muscle tissue is the glycogen. And at 20 mg per kg of Myozyme, under the conditions of this study, we still see glycogen. However, that glycogen is gone with our new enzyme. And finally, in terms of the preclinical work that we've done looking at how effective this drug is, we've done some functional measures in the mice. So these are some tests where we can look at the muscle function, we can treat the animals, and we can see how they respond. And we have 2 tests that we do this. And one of the tests is called a rotor rod. So basically we put these mice on a rod that just spins really quickly, and the mice have to run as fast as they can. And then we make it even harder because we switch the way it rotates, so the mice have to turn round and try and keep on there, and we measure how long they can do that before they fall off. So and then the other test is just simply a test of muscle strength, and this is even more basic. We take effectively a barbecue rack, and we have the mice hang on to the rack, and then we flip it upside down, and we time for how long these little mice can hang on to the barbecue rack before they fall. So that's a test of muscle strength. So we can do that, and we've done a lot of these experiments with Myozyme.